Hi, I'm Dr. Derek Lee. I have such an impressive guest today. He's renowned for his expertise in pediatric spine. He has published over 280 peer-reviewed papers and delivered over 800 national and international lectures. He has designed 5 lines of spinal implants and developed numerous surgical techniques adopted worldwide. Dr. Skaggs serves as the co-editor-in-chief of Orthopedics. He has edited multiple editions of top-selling textbooks in the field of pediatric orthopedics. He is the founding president of the Pediatric Spine Foundation, the treasurer of the Scoliosis Research Society, and served on the board of directors of the Pediatric Orthopedic Society of North America. He's a professor of orthopedics, neurosurgery, and pediatrics, director of spine, director of pediatric orthopedics, and executive vice chair of orthopedics at Cedars-Sinai Spine. Welcome, Dr. Skaggs.
Hey, Derek. Thank you. Please call me David.
Okay. I appreciate that. Now, today we're going to touch on a couple of topics, and I'd like to start off with athletes, young athletes and low back pain and spondies and your approach with robotics. Do you think robotics seems to be giving really good outcomes?
Yes. And although I'm a little hesitant to adopt new technology for new technology's sake, I think that the treatment of spondies in children and adults, for that matter, has really been vastly improved with the use of a robot. Admittedly, I don't use a robot for big scoliosis cases or for Sherman's kyphosis. I think that the studies show that if you use a robot for those big cases, it's just longer surgical time, bigger incisions, more incisions. For spondylolysis and spondylolisthesis, I think at this time with our present technology, we can give patients better care.
You have a presentation set up. Shall we take a look?
Okay, so let's first talk about Robot Assisted Spondylolysis Repair in young athletes. I have to thank all of my partners at Cedars-Sinai for teaching me, and particularly a neurosurgeon, Dr. Corey Walker, I jokingly refer to as my fellowship director, who taught me how to use robots to help kids. Let's just go right into a case. Here's a kid. We're looking at a CT scan of L5 that shows bilateral spondylolysis. Doctors like to make up big words. That just means that the spine's broken. And those aren't like breaks with a big gap between, but at the same time, this kid has been in pain for 18 months and nothing's been healing it. If you break your arm, it's pretty easy. You just put the arm in a cast. When you break your spine, you can't really put the spine in a cast so well, and bracing doesn't really work so well. And in this particular kid, we also got something called a bone scan. And we could see here that hotness suggests that, yeah, that broken bone really is the source of the pain. So what a robot allows us to do is very precisely plan exactly where to do surgery. I'm going to do something technically hard here. So look at up here in the upper, you see the path of that screw goes right across the broken bone. And what a robot allows us to do is not hurt that joint and not hurt that joint, put the screw in exactly the perfect place and not injure a nerve root here and not injure a joint there. So the robot allows us to be very precise. And what's neat also with the robot is you could see where the skin is. And if you have the trajectory of the 2 screws going through the skin at the same place, you can do this all in one incision. And I say that as maybe not really one incision. We have one thing here called a surveillance marker, another thing here that's the reference frame. And what this does is it allows the computer and the robot to see exactly where the person's bone is in space. And it'll let you, if you bump into one of these, it stops the machine so you don't make a mistake. At the time of surgery, we literally make a 2-centimeter incision. You can see it way down at the bottom, just a 2-centimeter incision. We watch real time as the screw is going into the perfect place. And then I like to be super careful. I say with pride that I am OCD about patient safety. We feel with a ball tip probe, we see here in this thing, a ball tip probe feels, and the surgeon says, yep, it feels like it's in bone. And then we image it from 2 different views and you say, yep, that's in bone. Then we put the screw in, confirm it's in bone with a fluoroscopy. And then we even touch the screw with an electrical probe to make certain that it is not touching a nerve. So we do multiple layers of safety to make sure everything's perfect. And I've now done this in 15 patients. And as far as I can tell, all 15 of these patients, the pain is relieved and they're going back to normal sports. As we can see here, this is a miracle to me. This is now done through a 2 centimeter incision. I never imagined I would be doing outpatient pediatric spine surgery. This kid, I didn't tell him to surf for 2 weeks, but he did, and he was pain free, never had pain again. We returned to all of his normal activities. And here's a nice text from the father a year later saying that he's doing well. He's playing baseball, he's surfing, he's lifting weights, hasn't had any pain for a year. At this point, it's a longer time. And this feels like a miracle to me. You truly get excited that we could offer this minimally invasive solution. At this point, there's elite athletes coming in from all over the country who have heard about this. So let me give the surgeons out there a heads up. When you first get your CT scan, if you do it too early, like we did this post-op week 5 because it was my first case and I was a little nervous, wanted to make sure everything was right. It looks like there's haloing around the screws. Now, one could misinterpret that as, is there infection? Is there loosening? But remember, these are HA-coated screws, which means the bone grows around it. And sure enough, by week 9, the bone has integrated into the screws. That halo-like appearance has disappeared. We even repeated it at 25 weeks. I generally don't do this many CTs, but just confirmed that there was complete healing. The screws are in the right place. Child returned to sports. And here's a young man who is a professional baseball player who is worried his career is over. He's now returned to professional baseball, pain-free. And here's a cool view. I call it the Walker view because Dr. Corey Walker invented it. If you tilt down the image, you could look right down the lamina to make sure you're in the right place. If you want to, of course, you could run a G-arm or an O-arm spin intraoperatively or some other type of 3D imaging. And so let me show you a case that didn't go so well. When I put in the ball tip probe here, like that's not in the right place. That's not in bone. I felt it. It didn't feel right. And we started to put in the drill and confirm, yeah, that drill's not in bone. Something's wrong. What happened here is where the robot arm touched the previous spinal instrumentation, it sent things in the wrong direction. So in this case, we just opened it up and did it the old-fashioned way. But I show this because we have to be very careful that what on the robot screen looked perfect. And I was only alerted to this not being perfect because 1, it didn't feel good. And 2, when we did the separate imaging, it didn't look good. Derek, do you want me to keep going or do you want to stop and ask questions or anything?
There has been some criticism, perhaps, that the younger surgeons should focus a lot more on manual dexterity and sensation and feeling experience before they up on the robotics bandwagon. Is that an accurate statement?
Yes, I think you bring up a really important point. So when the screw goes in place on the robot screen, it almost always looks perfect because that's what's planned. But if it doesn't feel perfect, it's not. And as you point out, when you're working through a robot arm, which could be 12, 15 inches long or so, you lose palpation, you lose that haptic feedback. So yes, if surgeons are trained only on a robot, they're perhaps trained without the normal haptic feedback. And I think you should probably put in a few thousand pedicle screws open by hand, feeling it to be the best robotic surgeon you could be. I think you bring up a really important point. In addition to this, we're developing new instruments to go through a robot that vibrate back and forth at 24,000 hertz that could give you the feeling of if you're in the right place in soft bone or if you're in the wrong place in hard bone. So yeah, you've identified a good problem and people are working to solve that.
I guess it also speaks to your example when the robot wasn't accurate and you had to open things up by hand. That gives you the ability to face complications as opposed to abandoning your surgery completely.
Yes. And yes, exactly. I think that many people say you shouldn't do something robotically or MIS that you can't do open. It's a nice thought, and I personally don't do that. But I do worry, what if somebody is so trained on MIS or robot, that's what they're best at, and they're not so good open? You may need like dinosaurs like me in the background that you can call up someday. He said, check out this movie here of the screw skiving off the top. That happens a fair amount when you have a really long robot arm. And if any soft tissue is pushing it out of the way and you're just 1 or 2 millimeters off, all of a sudden you could find yourself skiving, as we see here. Let me just show that one more time. I get a kick out of that. And why am I not being able to do this? There we go. So the screw could just skive off. How do you fix that? Here's one solution. Why not put in a guide wire? We verify it's in the right place. It feels good. It looks good on fluoro. And then put the screw in over the guide wire. What could go wrong here? Yes, but I'll show you what can go wrong. So I will show an error that I made in hopes that your viewers won't make this. I'm so worried about the guide wire going too far. What I should have done is pull out the guide wire basically as soon as the screw is threaded, or certainly by the time it goes across the fracture site. So if the fracture site is right there, as soon as the screw goes across the fracture site, pull out the guide wire and let it go the rest of the way. Now, fortunately, this guide wire is deep in the patient's bone and disc, never caused any symptoms, never had to be pulled out. He's far out of his surgery doing sports, but I feel the most honest thing we could do is share our mistakes so that others don't go there.
Completely appreciate that.
And so now let's look at a different type of thing here. This is a much larger gap. Now, if we just put a screw across here, is that going to heal? I don't know. I'd be worried about that. So we did something different. Step one is put in the 2 screws across the broken bones, just like we did with the last case. And now we're going to do something different. We're going to pretend with the robot to have a phantom screw that points right at the fracture site. So the fracture site is right there. We're going to set up the robot with the tube pointing at the broken bone. Then we're going to put in a guide wire. We're going to put tubes over it. And all of a sudden through the tubes, we're going to look down and we're going to see the fracture site. And we know we're there because we could see the screw going across the fracture site. And then through the tubes with the microscope, we could take out all the fibrous tissue. We could put in some new bone graft, and then it heals. And here's what this patient looked like before and after healing. Let me see. And you can see both from the lateral and the PA views, that big fracture gap is now healed. And I think I've done fracture gaps up to 7 millimeters this way. And as long as you bone graft it, they tend to heal. And here's an example of what the incisions look like. You have this 2-centimeter incision to put the screws in. You have another 2-centimeter incision or even less to put the tubes in to bone graft. And this patient has returned fully to football, basketball, weightlifting. After this heals, we know that bone is the only tissue in the human body that heals to 100% strength. So I routinely let the patients go back to full activities. So far, I have not had a rib break or any complications after that. And here's an example of an elite volleyball player that came from the East Coast. Parents are physicians, so they really did their homework. And we can see here there was a kind of substantial gap. And 12 weeks later, boy, is that fused. There is no question that this is fused and the child's returned to full sports pain-free. And what's notable here is we're not fusing across a disc. We're not getting anywhere near the nerves. We're not taking away a motion segment. We're just doing what orthopods do best, perhaps, is fix broken bones. So you want to talk about high-grade spondies? This is a whole different topic.
Why not? Let's go for it.
Okay, we might get into some controversy here. And let's start off with the case because I think that's always fun and makes it a little bit more personal. So we have a girl here who's 15 years old, level 10 gymnast, dreams of a college scholarship. And we can see that this is a high-grade spondylolisthesis where L5 is almost 100% off of S1. And we know that if you put L5 back into place, we're going to put the L5 nerve roots at risk. And there's always some surgeon at the podium saying, if you do it my way, it's safe. But we know from the SRS database that this is the one surgery in which complications have increased over time. And I think that as surgeons become more aggressive trying to put L5 back into place, more nerves are being injured. So we do a conservative approach. And I think the Finnish have really good long-term studies on this, showing that if you leave L5 in front of S1, we have this screw that goes right across S1, the disc, and L5, we can make it rock solid. all from the back, and there's almost no risk to the nerve from stretch because you're not reducing. And some of the technical points, if you're doing it with the robot, you can pretty easily line up all the screws. And we want to leave the tulip for L5 a bit high, so all the screws line up and we could just pop the rods into place. And here's an example of the robot planning, making sure we go through Squillia, through S1, across the disc, and into L5. And here's what this child looked like afterwards. L5 is just where we want it. And if anything, we don't necessarily try to put L5 back on S1, but we do want to restore lordosis. And in general, as long as you get S1 to L4 somewhere around 45 degrees, we're probably okay. And here's what she looked like 3 months post-operatively. And here's what she looks like standing. The family's given permission to use this for teaching purposes. And we could see, even though in the X-ray L5 is in front of S1, she looks fantastic in person. And I think that she has been saved from the risk of permanent nerve injury. And as a sidelight, she did get a Division I scholarship in gymnastics, and she's proceeded full career without having any problems from the surgery. So that's all I got.
No, that's great. Is that a fusion of L5 on S1 at that point?
Yes. And what's interesting is I think because you have screws at L5 and from S1 up to L5, you have the screws are triangulating. Thus far in my career, I've never had one of those fail. I've been doing this surgery for about 25 years. I think you're getting anterior support from a posterior approach.
Because it seems that spine surgeons like to reduce or correct as much as possible, right? And sometimes to the detriment of functionality.
Yeah, I have to admit, sometimes my ego wants to put it back in place and make it look straight. And it takes a lot of discipline not to do that. I think overall, I really think if parents sometimes recognized how often some of these risks and complications happen, they would probably choose a little bit safer pathway. I think that surgeons may have a little bit higher risk tolerance than parents.
Yes. And it does seem that more surgeons are moving away from symmetry and perfection towards much more towards functionality and a reduction of complications over time.
Yes. Yeah. The goal is a functional, happy, safe patient, not a perfect X-ray. Yeah. And I think it's a good movement that we're doing towards patient-reported outcomes. Patients should tell us how happy are they, how pain-free are they, and that should really be one of our guiding principles.
Absolutely. Now, you mentioned before that you're a pediatric spine surgeon, but you're moving into the adult world, or you already have moved into the adult world.
Yes and no. Yes. So, I'm orthopedic co-director of the spine service at Cedars. It's the second biggest spine service in the country. Hospital for Special Surgery is first. My personal practice is pediatrics, but boy, have I been learning hanging out with a bunch of adult spine surgeons. I didn't realize, honestly, how little I knew about spine surgery until I found out what happens when people get into their 20s, 30s, and 60s. So I now have a much broader view of a lifetime of spine rather than just what happens to kids.
Dr. Skaggs, I want to thank you so much for your time. You're such a great speaker, by the way. I think I want to be you in terms of when I do my future presentations and interviews.
It's an honor to spend some time with you, Derek. Thank you.
Likewise. Terrific.
Good.
Thank you.